Bom dia a todos, bem-vindo à nossa reunião semanal da disciplina de Urologia. Hoje nós temos uma convidada especial, professora, então nós vamos fazer a apresentação em inglês. Good morning, everyone. Welcome to our weekly meeting at the University of Campinas. Today we have a professor invited, Professor Desiree Vrijens, from the University of Maastricht, the Netherlands. And we start our meeting with a discussion, a case. After Professor Desiree will present a lecture about multiple sclerosis. Dr. Barbara Veronesi is 5th grade residency in neurology, and she will present a case for our discussion. Good morning, Barbara. Please, you can start.
Good morning. My name is Barbara. I'm a medical resident, and we are going to present cases right now. Or do you want to wait a little?
No, you can start. Desiree is already is in the room.
Good morning, Dr. Desiree. Can you see me?
Yes.
Okay. Well, the first case I'm going to present for discussion, it's a woman with 66 years old who already came with a previous diagnosis of multiple sclerosis. She does her follow-up with neurologist since 2000. Well, from that, she's well controlled with no new neurological symptoms from now. She walks normally and no problem from that. But she started to have urinary symptoms at 2016, and then she came for us. Well, her symptoms was urgency with bothersome, incontinence, and nocturia, also polyuria. She woke up around 6 times at night to urinate, and at the conversation, she urinates at every half hour with urgency and some episodes of incontinence. At this first moment, she was prescribed sulfenacin and pelvic physiotherapy. At first, she had a good control of symptoms, but she complained really about side effects, especially constipation and dry mouth. Because of that, she abandoned treatment, and because she didn't want to use that anymore. Then her symptoms came back. It was prescribed mirbetriq.
Barbara, let's stop a little bit. I would like to ask to Cássio Riceto. You have a great experience on many antimuscarinic drugs. When you have side effects of one drug, you try to change the other antimuscarinic. What you do when you have side effects? Cássio?
Good morning. Good morning. We have two options here. We can try to change for another someone more specific to M3 receptors, like derifenacin, for example, or change the drug class and go to beta-3 adrenergic agonist, like in this case. I don't know to explain what is the, we have to try and feel the patient.
Okay. Okay. Continuing, Barbara.
Okay. Now, using mirbetriq, she came back with the same symptoms. And then at this time, we requested urodynamic evaluation. At this urodynamics, we can see that the filling time, she didn't have no Detrusor overactivity, but she had a good maximum capacity, around 350 milliliters. But when we requested her to urinate, she started to do abdominal pressure, that also with the Detrusor contraction, but with a very low flow, urinate flow.
Wait, Barbara. I'd like to, good morning, Desiree. I would like to ask you about this urodynamic study. Not frequently you have a very low capacity in the urodynamic in this type of patient. What's your experience in this sclerosis, multiple sclerosis patients? Desiree?
Sorry. Yeah. Now you hear me. Sorry. Yes. That in patients with multiple sclerosis, that not so much the capacity is a problem, but it depends on the stage of the disease. But most often that they have either Detrusor overactivity or residual urine. Yes,
you believe because this patient wait quite long to start treatment of urinary symptoms. This like other neurogenic disease. When you don't treat the bladder became low capacity, high pressure, and this decrease compliance, everything. You see it happen as a similar or other neurogenic disease.
Yes, yes, but not so often, because in the Netherlands the neurologist refers them rather soon to the urologists. So mostly we see the patients not in a very advanced stage, but earlier on in the disease.
This is very interesting. So the neurologist sent to you the patient at the beginning of the diagnosis?
No, not straight away, but quite early on.
Okay. Okay, thank you.
Yes.
Barbara, can you continue?
Okay. Then we decided to apply intravesical botulinum toxin injection. After that, she had an improvement of symptoms and could increase the interval between urination. She was well satisfied with this treatment at this time after botulinum toxin. But 3 months later, her symptoms came back. And then she required another application because she really liked the result.
Okay, I want to ask to reset again. What's the dose you start to apply for botulinum toxin? And this patient have a short-term recurrence of the symptoms. You try to increase the dosage of botulinum toxin in this case?
I used to start with 200 units in a case like this with established neurogenic cause. But as she evolved with premature recurrence, I moved to 300 units, I think. But I'd like to come back a little bit to urodynamic examination, Professor Carlos, because I saw the voiding pattern of this patient, and probably she has some kind of dysfunctional voiding because the flow is very low. I'd like to ask, and for Professor, the usefulness of repeat the voiding phase of urodynamics when we are assessing this kind of patient, because only one measure, I don't know if it's representative. I don't know. What do you think about this?
Yes, thank you for the question. I always try to do 2 fillings and sometimes even 3, but especially the voiding phase can be difficult for patients, that it's not representative to the normal situation because they have to void with a catheter in. So in order to see for the voiding phase, I would prefer a free flow. So not only the urodynamics, because you need that for your filling phase, but for the voiding phase, a free flow. And when there is dysfunctional voiding, physical therapy could help.
Okay, and about...
But not very frequent to have a dysfunctional voiding in this type of patient, right?
Sorry, I couldn't understand it.
It's not very frequent to diagnosis of dysfunctional voiding in this type of patient.
No, it's not. You're right. It's most often Detrusor. If you see it like this, and you that can be Detrusor sphincter dyssynergia as well.
Okay. So Cassio, you try to do physiotherapy in this patient, or have it done, but you try to use also Botox in the bladder neck.
If the Detrusor sphincter synergia is very representative, and especially if we have electromyography of or video aerodynamics showing this pattern, I think it's useful to inject in the sphincter. But I don't have a lot of experience with this situation.
Okay. Barbara, you have something more to comment on this case?
Yeah. As she required, we did another application of intravesical botulinum toxin. But then she returns with improvement of daily symptoms, but recurrent urinary tract infection, non-complicated. Do you think the interval between applications was around maybe too low?
Desiree, what's your experience with botulinum toxin in this type of patient? How often you do application of this botulinum, and what's the dose you apply?
So in general, with patients with neurogenic bladder, I applied every 6 months. And even if it's still working or not, I apply it at regular intervals, and I use 200. And in exceptions, I move up to 300. But with the neurogenic population, mostly 200 is fine. Sometimes it's required to do it a bit earlier, but never within the 3 months, because otherwise the interval is too short.
Okay, but if you increase the dosage of botulinum toxin, you have more risk to urinary retention.
Oh, yes.
And this is not
Yes, but I only perform when they are willing. I do Botox when they are willing to perform clean intermittent self-catheterization.
Okay.
I always discuss that beforehand, and most often I learn it to patients beforehand. And when they're not able to do it, then you have to think about it again before you apply the botulinum toxin, I think.
Okay, this patient don't respond well with pharmacological treatment, neither botulinum toxin. So what is the option now, Desiree? What you treat this patient don't respond to botulinum toxin?
But what is the complaint? Does she have residual volume after voiding with the second course of botulinum toxin?
Barbara, you can comment.
I didn't understood the question.
Does she have residual urine after voiding? No, she voids perfectly.
She takes a little long, but she can urinate everything.
Okay, but what is her problem? Why doesn't it react? Has she got urgency or frequency or nighttime voiding?
So she can continue with the symptoms of frequency, nocturia, and sometimes also incontinence.
And did you repeat the urodynamics after the second Botox or not?
Barbara?
No.
I don't know. It's quite difficult that she still has got this problem. If you have used all the medications, Sometimes you can use PTNS, but mostly you can also do that before the Botox. Do you use PTNS, percutaneous tibial nerve stimulation, in patients with MS?
We use transcutaneous stimulation.
Mm-hmm.
And we have a group study which is multiple sclerosis, works very well. But this patient underwent this treatment and don't have good response.
Okay. So I'm curious, what did you do with the patient?
No, I want to discuss with you two types of treatment.
Yes.
Neuromodulation in this patient and bladder augmentation. What opinion these two types of treatment?
Yes. So with the sacral neuromodulation, we sometimes do it with patients with MS, but our success isn't very, very good, especially when they've got a relapse or when the disease progresses, then you see that it doesn't work anymore. So, but when the MS is stable for more than 6 till 12 months, then we try sacral neuromodulation. But in general, the effects aren't very good. So I missed some part of the urodynamics before the thing. What was her bladder compliance? Was it reduced?
The maximum symptomatic capacity reduced, the compliance normal.
Okay, and what was her maximum capacity then, before the Botox?
400 milliliters.
Yes, but with 400 milliliters, you don't think, normally you wouldn't do an bladder augmentation, would you?
No. But in the literature, they said if no response, no treatment, you can use bladder augmentation. We don't have experience in this type of patient. I want to know if you have done some cases, bladder augmentation in multiple sclerosis.
No, I have not. Only in spinal cord injury patients.
Yeah.
But not in MS patients.
In this patient, sometimes have relapse and necessary to perform magnetic resonance, MRI. And if you have implanted neuromodulation, have some problem.
Yes. But unfortunately now the new neuromodulations are MRI compatible, but you only have to put it out. But in the past, we have explanted patients who were in need of an MRI. It depends. If it's an MRI of the head, there are some radiologists who are willing to do it with an implanted a sacral neuromodulator, but then turned off. But when there has been a spinal MRI needed, we needed to explant the patient, unfortunately.
What's happened if you perform MRI in sacral neuromodulation? This heating the electrode, what's happened?
Yeah, I mean, I'm talking about the old electrodes and the IPG, because now it's the new ones are MRI compatible, but there is a change in temperature which they are afraid of. But I've only seen a problem with the MRI once, and we do a lot of sacral neuromodulators, and we do a lot of MRIs with the sacral neuromodulator, but only once that it didn't work anymore after the MRI.
Okay. So Barbara, you can so what's happened now? What you perform?
Yeah, it was implanted sacral neuromodulation, the intestine, and then the patient had a very good control of symptoms with a urination interval of around 1.5 hours. She drinks a lot of water because of her medications, and nocturia around 3 times yet, but with not worsening her quality of life. She then have a few episodes of incontinence, but it doesn't bother her. And she's now without any urinary tract infection, and she really felt an improvement of quality of life. Very well satisfied.
That's very good.
Some advice for this patient, Desiree?
Yeah, I mean, in order to try to prevent urinary tract infections as much as possible. So I think that her drinking a lot is very good. Sometimes I put patients on D-mannose in order to prevent a urinary tract infection and not on continuous antibiotics. Yes, but I think it's very good that she responds so well.
So, to give us a recommendation, if the patient then probably 2, 3, 5 years and returns the symptoms, you believe this can perform a blood augmentation or just what you're doing?
Yeah, it depends on the symptoms. I would perform again a video urodynamics in order to see how is the bladder, how is the upper tract, is the reflux of the kidney, bilateral reflux to the kidneys. And then you can see about the symptoms. Sometimes you could re-perform Botox again, or do a bladder augmentation. But as I said before, I have never done it in a patient with MS.
Okay.
A lot of patients end up with a permanent indwelling catheter, unfortunately, when they're not mobile enough anymore. How is that in your hospital?
Sorry?
How is that in your hospital? I said, unfortunately, a lot of people end up with an indwelling catheter when they're not mobile enough anymore and when they're wheelchair bound.
Yeah, this is a problem. When it became more, the disease progressed, it's very difficult to treat this patient. Much time stay in the line catheter because I can do intermittent catheterization, very difficult to treat this patient in this case.
Yes, and at that moment, they're not motivated enough anymore to do big surgery because their situation is quite bad, actually.
Okay, very good discussion about this case, and you prepare a presentation about multiple sclerosis. If you can start your presentation.
Yes.
Perfect.
Is the presentation on?
Not yet.
Can you see the? Not
yes.
yet.
Oh, yes.
No, it is.
No,
okay,
no, it's okay.
It's okay. I can start.
Yes, please.
Okay, thank you very much. So, multiple sclerosis and lower urinary tract dysfunction. So, as we all know, that MS is characterized by a chronic autoimmune T-cell mediated inflammation of the central nervous system, which leads to disruption of the myelin sheaths. And the prevalence in Europe is around 83 up over 100,000 people. And the whole neurological system can be involved. And there are different subtypes according to the clinical course. And the most common is the relapsing remitting. So you have a SHUP and then it gets better, it gets worse, it gets better again. It's around 70 to 85%. And as you see on the top image, that half of the patients progress to secondary progressive form. There is also a benign relapsing remitting, which doesn't deteriorate so badly. It's around 10 to 15%. And around 10 to 20% have got a primary progressive form. So they have got a progressive symptoms from the onset. And this is the group who do worse in terms of quality of life, and they progress rather quickly. When you see on the expanded disability scale, status scale, which is very often used within the MS population, and there you can see how much the disease progresses from 0, which is totally mobile, to 10, the death. And the median time to progress from EDS 4 to 6. So 4 is able to walk and 6, you need constant help to walk 100 meters, is between 6 and 8 years. When this time is shorter, it says something about the prognosis. So the longer the deterioration takes to go from 4 till 6, the better the prognosis is. Unfortunately, this expanded disability status scale doesn't say anything about the bladder. There are no bladder things in it. What I said before, so MS can affect any part of the central nervous system. So lower urinary tract dysfunction can vary and can combine, and it's mostly because of spinal cord disease. And there's shown that there is a correlation between the lower urinary tract symptoms and the degree of the pyramidal symptoms in the lower limbs. So as I said before, MS is very often progressive, and therefore the bladder symptoms can change. But it's not only due to the direct neurological problems that there are problems with lower urinary tract dysfunction. For example, the cognitive problems can play a role, or there can be other urological problems, for example, bladder outlet obstruction due to BPH, or a urinary tract infection, or in women maybe also stress urinary incontinence. And due to the reduced mobility, also functional incontinence can be very important, or other medications, for example, opiates, which reduce bladder contractility, or antidepressants. And when you look at urodynamic studies and lower urinary tract dysfunction, you can see most often Detrusor overactivity. And the Detrusor overactivity is mostly due to subcortical white matter lesions. And when it's also in the bladder cord, you can also have Detrusor sphincter dyssynergia combined. But also Detrusor underactivity, 25%, and a reduced bladder compliance is limited between 2 and 10%. This is a table of percentage of people with MS who experience lower urinary tract symptoms. And this was rather groups with lower scales, so better MS people, so to say. So not totally wheelchair-bound or bed-bound patients, because you can see the retention rates are relatively low, between 2 and 20. It's mostly urgency and frequency, between 60 and 80% urgency, frequency between 50 and 83%. And the incontinence varies quite a lot between these studies, between 19 and 83%. But when you take a history, it has been shown that the bladder is an unreliable witness. So there is often is there incomplete bladder emptying and overactive bladder, which can coexist and which can exacerbate the overactive bladder symptoms. And this is a cohort of 170 patients with MS. And when they were asked, do you empty your bladder? Do you think your bladder is empty after voiding? So patients who thought they emptied their bladder well, they were often correct. So 83 of the patients said, I don't have any, I cannot empty my bladder. They were right. But sometimes they thought their bladder was empty, but it was not empty. So it was only 50% correct. So it's very important to measure the residual urine. What about MS and the kidney? There is no renal failure in MS. I put it between brackets because it's not 100% true, of course, but mostly in spinal cord injury and spina bifida, so those kind of neurological bladders, we know that renal failure is a real option, but that's not so much the case in MS. And upper urinary tract damage varies between 0 and 25, so quite varies, but there are some few risk factors. So the long duration of the disease, the matter of disability, the permanent indwelling catheter, or high amplitudes of Detrusor overactivity. And so the need to perform complete urodynamic studies in MS is somewhat controversial. For example, the NICE guidelines and guidelines from the UK, they say you put it later in the disease when medications or other therapies fail. But for example, the French guideline put it quite early. So maybe that's a point of discussion we can have later about when to perform urodynamic studies in multiple sclerosis. So what do you do? There are different guidelines. For example, this comes from UK guidelines. When you've got urgency frequency, you test for urinary tract infection, you measure the post-void residual. Is it less than 100? You can treat with medication. Is it more than 100? You could start with clean intermittent self-catheterization. And it's also said that you have to repeat the measure of the post-void residual. So management, what I said before, MS is a progressive disease. And with the progression of MS, the risk of the urinary tract increases. And therefore also the therapy is different. Now, what kind of therapies early on in the treatment? Fluid intake, you can manage that because we know that patients with overactive bladder symptoms often reduce their fluid intake, which puts them more at risk, for example, for urinary tract infections. Physical therapy could be an option in patients with MS, for example, for overactive bladder symptoms, but also sometimes relaxation symptoms when there is underactive bladder. But it's only feasible in patients with an intact pelvic floor. There is also a study done in a Belgium study who compared intravaginal electric stimulation with biofeedback and to stimulate the pelvic floor muscles and therefore have an inhibitory effect on the Detrusor overactivity. It worked without any harm, but as I said before, it's a small study. Clean intermittent catheterization is rarely needed in the first stages of the disease, but it's often more needed when mobility deteriorates. Then antimuscarinics, we all use that in idiopathic overactive bladder. We use it in MS, but actually the evidence in MS is rather low. There are studies with very good results, but we have to be aware of the reduced detrusor contraction and maybe therefore an increased post-void residual. And has been said that it works better in combination with clean intermittent catheterization. What about desmopressin? Desmopressin is a synthetic antidiuretic hormone. It reduced nighttime frequency, as we know, but there is also a study which shows that there is also reduced daytime frequency for up to 6 hours without a rebound nocturia. But it's in clinical use, it might be limited because you can only, it's advised to use desmopressin only once every 24 hours. So it can improve the sleep efficiency, but we have to be aware of hyponatremia. So we have to check the sodium after 3 and 7 days of start of treatment. So mirabegron is a beta-3 receptor agonist. There is not much evidence in MS, but there is a small group study which says it works in combination with desmopressin, so it's something we could consider. Then, as we heard of the patient, botulinum toxin A, very effective, but with high risk of clean intermittent catheterization. It might also be applicable to prevent leakage in an indwelling catheter, and also with a patient who has got urinary tract infections, you might use it. PTNS, we discussed it before, so the percutaneous tibial nerve stimulation, either with a needle or with an adhesive pad, can be very effective in managing storage symptoms. Sacral nerve modulation, in the literature, there's limited success, and especially because it can lose its efficacy when the disease progresses. So here it's nicely in a scheme that you can see that as the disease progresses, there are different treatment options. So in the beginning of the disease, blood retraining, fluid intake, exercises. Then later on, medications in combination with intermittent catheterization, tibial nerve stimulation or sacral nerve stimulation, botulinum toxin, and at the end, in permanent indwelling catheter or maybe surgery. So to conclude, I think MS is a progressive disease in general, and evaluation and treatment must be changed accordingly. So you have to reevaluate the patient when there is disease progression. And we need multidisciplinary follow-up, preferably, to improve quality of life and prevent complications. Thank you very much for the attention, and thank you very much, Professor Carlos, for the invitation.
Thank you very much, Desiree. Very nice presentation. And I would like to open for questions from the people listening you. Any question?
I have a question. I have a for Professor Desiree about the follow-up of these patients. If what's our routine in Maastricht? If you use some kind of special questionnaire, or how you do with bladder diary with these patients, because for us it's very difficult to have the real information about how these patients are really doing in the follow-up.
Yes, that's right. So what is the exact problem that you have with the bladder diaries? They don't fill them out, or what is the problem that you experience?
Exactly, it's not reliable here in Brazil. So if you have a questionnaire, it's important for us.
Mm-hmm. Yes. Yes, I don't use so much the questionnaires, to be honest. I ask the patients, I rather go but what the patient tells me. So for example, when he or she is pleased, when there is not much leakage, of course I ask for bladder diaries, especially for the how do you say it, the bladder capacity in daily life. I ask for the bladder diaries, and I do regular intervals, flow and residue, when they are able to void at the toilet in our outpatients clinic.
Okay, Desiree, you emphasize very much the post-void residual.
Okay.
Why is so important in this case to measure the post-void residual?
Because when you've got increased post-void residual, you've got increased risk of urinary tract infection. And with a urinary tract infection, you could have a deterioration of the MS. So, and especially when the disease deteriorates, I check it again. But when there is a stable patient who's been on the medication, who does not any post-void residual, I don't check it every few months. Then I only see the patients once a year, and they come back earlier when there are problems. So what I would like to ask you, how many times do you perform an ultrasound of the kidney? Because in spinal cord injury and in spina bifida patients, I do it very regularly, something like once every year. But with the MS patients, I don't perform it so regularly. What's your opinion about that?
Cassius, can you answer?
No.
Well, normally we use ultrasound every year in neurogenic bladder. We have few patients with MS, but I believe we can also follow this recommendation.
Yes, yes. Well, with the other patients, I perform the ultrasound at the radiology departments, and in the MS patients you put the ultrasound. It's much easier yourself, but I hardly ever see any difference in the kidneys. Have you seen?
You also believe it's important to measure the detrusor thickness in this patient can help you for the treatment decision?
No, I don't use the measurement of the detrusor thickness because I think it can be rather, it's not very reliable, I think, because at least with the ultrasound that we use, and also because it also depends on the volume of the bladder, so how much that there is inside of the bladder. So I think when the kidney function is good and you don't have any dilatation of the kidney, I don't, how do you say it? I'm not only trusting the Detrusor thickness. Do you use it in clinical practice?
Yes, we use a lot, mostly in the BPH patient, because if you have a high pressure, you have a thickened bladder, so you have a risk of upper urinary tract. But the Detrusor is normal, the risk is low, and probably the pressure is low. So no risk in the upper tract if your bladder pressure is low. You agree?
Yes, I agree. What kind, do you have got a specific protocol of the bladder filling, of the amount of bladder filling when performing the ultrasound of the bladder thickness wall?
We follow the recommendation Matthias Oak, about 250 ml in the bladder.
Oh, yes.
And increase this, take a picture and increase 10 times the picture to measure the Detrusor thickness.
Okay. Yeah, the ultrasound that we use in our practice, unfortunately, isn't able to do that. We should talk about it, I think.
Yes, we fight sometimes with the radiologists when they don't do this.
Yes, yes.
What do you think is more important to evaluate the patient? The post-voidal residual, urgency, frequency, or urinary incontinence? What's the symptoms more important to follow and to change treatment in this patient?
I think that's a very difficult question, because the urgency urgency and incontinence is often more important for the patients than themselves. Well, the residue, they cannot, what do you say it? They don't know it for this. They can tell you if they've got urgency, they can tell you if they've got leakage, but they cannot reliably tell you if they void their bladder empty, if they empty their bladder well enough.
Okay.
So, therefore, you check it as well.
You use some algorithm to follow or to diagnose this patient? You use some algorithm?
Yes, but it's not different than any other neurogenic patients.
Okay.
So I don't have a specific algorithm for the MS population. Do you?
No, I just want to learn more with you.
Yes. I saw a question going around if there is a difference between treatment of the MS patients in women than in men. Yes, in men, you more often also use, I said, tamsulosin, or to relax the blood. I forgot the medication now. So there is a lot of BPH in men as well. So you have to treat the BPH part of the MS patient as well. Okay.
You address also the importance of urinary tract infection. You don't use antibiotics prophylaxis, you use demanose.
Yes, I use antibiotic prophylaxis as well, but you try to prevent it, because although you use nitrofurantoin or trimethoprim, there is still risk of antibiotic resistance. Okay. So when it's not needed, I try to avoid it. And then I use, for example, demanose. There are a few studies, especially in MS patients, that it helps. And with a lot of drinking and all the sort of normal things. I sometimes, although the evidence is maybe not so good, cranberries as well. So when it's not needed, I try to avoid prophylactic antibiotics. Perfect.
Any more questions? So we have time, Barbara. You have another case we can discuss?
I have a question.
Perfect, Castro.
No, I have a question.
Go ahead.
Pain in patients, about pelvic pain in female patients with multiple sclerosis. If Professor Desiree has an experience with this situation, because in my office I have sometimes some patients with concerns of pelvic pain, probably related to a hypertonic pelvic floor, that it's very difficult to manage them We use myoblockers, but it's not worked so well. What's your opinion about this?
Yes, that's a very, very difficult question. Personally, I don't have any experience of pelvic floor pain in combination with people with MS, but of course it can co-occur. But I do have experience with chronic pelvic pain in patients without any neurological disease, and it's a very difficult disease to treat. Some patients try to take opioids, and then I try to reduce the opioids or stop them. I give them pelvic floor therapy. But I also do a lot of, because when you ask those patients, a lot of those patients have got other problems as well. For example, overactive bladder or irritable bowel syndromes or fibromyalgia or chronic fatigue. And when you ask them and you see several different sort of diseases or symptom complexes come together, I often see them together with a psychiatrist. And we start SSRI, so a selective serotonin reuptake inhibitor. And then, because when you talk to the patients, they often have got anxiety problems or depression problems as well. And when you combine the treatment, so to attack the pelvic floor with normal measurements, so prevent urinary tract infections, pelvic floor physiotherapy, together with central working medication when there is an effective complaint, so anxiety, depression with it as well, we get very good results. But it's a very difficult, not always good result, but it's a very difficult problem to address.
Okay, perfect.
Okay, thank you.
So, Barbara, we have time to discuss more one case.
Okay. Can you see me? Next patient, it's also a woman with 36 years old. It's a patient who has urinary incontinence since 19 years old, associated with urgency and polyuria, nocturia, and dysuria. She refers urination around 20 times a day and wakes up around 3 to 4 times at night. With her pathological history, she had 2 kids. One was the liver was normal, other was surgical, and she has a lumbar spine disc hernia, which causes her some difficulty to walk. She also has anxiety and hypertension, well controlled with medication, and she denies any surgery. At the physical examination, it was normal. She didn't have any prolapse and didn't have loss of urine with abdominal pressure. Once she got this complaint a very long time, she had already used oxybutynin and sulfonamide for around two years, but without any improvement of symptoms. She also had performed physiotherapy with some improvement. At this point, we requested urodynamics for a better evaluation. At the urodynamics, we can see that she had Detrusor overactivity since 100 milliliters, which is very strong and symptomatic, causing urinary loss. The maximum capacity was around 125 milliliters, but I believe that's due to the Detrusor of overactivity, because when we requested her to urinate, she had a short flow, but with almost no residual. I guess she had lost almost of the liquid. and she also had a Detrusor overactivity after the urination, which was symptomatic. She referred a struggle to urinate after it finished. Do you want to comment the next one, Professor?
Castro, want to comment this dynamics?
And the patient has premature contractions in feeding phase, high amplitudes, and I don't the capacity is very low, okay, and it's quite difficult to make comments about the voiding phase, because what is the maximum? What's the key max, Barbara?
Was almost 5, because at the time she decided to she couldn't handle anymore. We programmed the flow phase, which
Yes,
there was not much volume to urinate.
Yeah. The voiding phase is not representative for analysis. I think it's the Detrusor activity very impressive in this curve, Professor Carlos.
Yep. Yeah, I agree with you. Very overactive bladder, Detrusor, the overactivity, and I don't understand well this story, Barbara. The patient have some injury of the spinal cord because hernia like this?
Yeah, she has disc hernia, which causes her some struggle to walk, but she referred that was waiting for surgery, but was never performed.
Okay. So this is a very difficult case because have a hernia, is probably compressed the spinal cord and have a neurogenic bladder. So, Desiree, what happened when the patient still waiting for a surgery?
I would do botulinum toxin, I think, when she's able to perform catheterization, and she will be because she's rather young. And then it gives you some time that when she gets the operation and then the Botox works out, and then you can reevaluate the voiding problems.
The big risk because we are waiting for the surgery. Sometimes the damage occurs in the spinal cord, not reversible. This is a big challenge.
Yes.
So, Barbara, what the treatment underwent?
Yeah, we had that concern about urinary retention. Then we made the training of clean catheterization, and then we performed botulinum toxin with 200 units, and then she had the improvement of symptoms, but it was 4 months. After 4 months, she referred that urgency came back, and she's waiting to get 6 months for a new application.
And now?
We're at this time of the case. She's still waiting for new application.
And what about hernia surgery? Is that still happening? Is she on the waiting list or not anymore?
She said she's in the waiting list,
okay.
But it's a little difficult.
Okay.
So it's not on the waiting list, or she's underwent surgery?
No, she didn't underwent surgery. She refers to be on the waiting list.
Okay. Okay, I believe we don't have much to do. Repeat botulinum toxin, how Desiree said, wait the surgery. And after the surgery, we can study against the patient, not do any surgical procedure, more aggressive surgical procedure until what?
Okay.
Yes.
Any different comments, Desiree?
No, I would do the same.
Yeah. Okay. Cassio.
No,
You have
no
experience.
comment. It's
Okay. Desiree, we have some patient which botulinum toxin underwent bladder retention and need self-catheterization, and the patient became very upset. It's very difficult to convince a patient to perform intermittent catheterization. How you advise a patient in your unit?
Yes, we've got the similar as well, because sometimes the patients they don't want to do that. What we have a special trained nurse, and they give them a long consultation, and we try to explain all the pros and cons of intermittent catheterization, and try to make use of several different catheters in order to convince them to do perform intermittent catheterization. But sometimes then you need to put an indwelling catheter for a short time until the Botox wears off a bit more. But mostly when we are in doubt, or we think that intermittent catheterization is a real risk, we learn to perform intermittent catheterization before the Botox. Okay. And if they say, no, I'm not willing to do this, then we don't perform the Botox.
And for how long you use Botox? How many years you can repeat? How many times you can repeat the Botox? Because very different in the response in the literature.
Yes. As far as I know, there are not many concerns so far about repetition, but it's more that the patient compliance, that they don't want to do that anymore. Tom Marcelissen did a study about repetition of Botox, and one see that patients refuse more Botox treatments after 3-4 times. Then either they want to have something more permanent, or they disappear and they live with their complaints.
Okay. Okay, we are in the end of my meeting. I would like to thank very much you, Desiree, to your time and share with us your experience. And thank you for everybody to come to our meeting, and invite all you for the next week, our regular meeting in Wednesday. Thank you very much, everybody. Bye-bye.
Thank you very much. Bye-bye.
Hi.
Thank you.
Thank you.